Good day, everyone, and welcome to today's Black Health Trust. We're glad that you're with us today, and I would like to turn our episode over to our founder, Dr. Randall Maxey.
Good morning, Dr. Walks. I wish I had gone to church with you this morning.
I wish you had gone to church with me too, Dr. Maxey. I don't see your camera on, but I can hear you.
Okay, well, I'm glad you told me. I'll turn my camera on. I was reading an article that was a little bit disturbing
Hmm.
about the erstwhile first Black president of Harvard University. And we
Hmm.
spoke about this a week or so ago. And some people said, well, maybe the people who went to Harvard should object to her being fired or put in disrepute. And turns out that, as we predicted, not only did they persist and get her out, but two billionaires admitted and were quite joyous that they had led a formal campaign to get rid of her. And they got rid of her because they said she was anti Semitic. And they also got rid of her because they said she plagiarized. And one of the billionaires that did it was a guy named Bill Ackerman. And he softened his tone once his own wife had to admit to plagiarism this week. So we can see that there's a concerted effort to discredit blacks in general and women in particular, and we should be very aware of what's going on. And it's this reason that people are afraid to speak out because there's so many billionaires in this anti-Semitic group, a group that is offended by anti-Semitism, that they only see that. They don't see anybody else's pain, anybody else's problems, except if you're anti-Semitic, they'll get rid of you. So we should know that, and maybe we'll deal with that on one of our programs.
Well,
It,
Dr. Maxey, let me just add that um, we here at Black Health Trust we have addressed concerns about anti-Semitism. We have had open discussions about that, and we are not advocating anti-Semitism. I think the
correct.
what you're pointing out is that when someone mentions that someone may be espousing views that are anti-Semitic, they're quick to just throw everybody out. And so we are very clear that we do not support anti-Semitism here on Black Health Trust. We support um, folks getting a fair shake, and we support people not being thrown out without some sort of due process.
Exactly. And we do reject people being single-mindedly just
Mhm.
about anti-Semitism. We
Right.
want we want you to be human and anti people who are anti-human, whether you're black, whether you're Semitic or whatever. So that's what
Agreed.
I say. I appreciate your clarification. We have a wonderful topic and speaker this morning, and someone who's been with us for a number of years and has brought previous programs to the fore. And today's topic is mental health concerns in women. And Dr. Waltz, I'd like you to introduce the esteemed Dr. William Lawson.
Uh, Dr. Maxey, unless we have a 3-hour program, I don't have time to do justice to Dr. Lawson's incredible history of service to, I was going to say to our culture and our country, but actually Dr. Lawson is well respected and his contributions are well respected internationally. He has been a renowned professor at multiple universities, including Texas and Howard University. He continues to lead in his field. We mentioned earlier before the program was formally started about his recent book on African American health. Dr. Lawson is an MD, he's a PhD. I think all the letters of the alphabet are included at some point in his overall introduction. We are just very honored every time Dr. Lawson is able to join us. And with no further ado, I will I will stop with the 35 other things I should mention and just introduce Dr. William Lawson. Thanks for being with us. Oh, and I forgot to mention, he is a fellow psychiatrist and a prominent one at that. Thank you, Dr. Lawson, for being with us.
And semi-retired, I think. Let's see, did we get it? Yeah, I'm sharing. Where's the little button? I'm looking for the little.
I think the little slideshow button is all the way down and over. Is that the one we're looking for?
Yeah, and I just got a new.
It looks like a little movie screen.
Okay. Stuff, all the way down. Still looking. Apologize, folks.
You want to hit the back button. You were where you wanted to be in terms of the presentation. Right. Now, if you go down where it says autosave and then go to your, nope, not that one. Where it says autosave and then go over to the right. Yep, keep going. There you go. That should
Oh, there we go. Now, are you guys able to see it?
We're still seeing the same screen. There's a little screen that looks just like that one that's all the way down on the below your slides and over to the right, where you can read display settings. I'm trying to sound like I'm the expert here, but I'm really not with respect
Anyway, you can show him where to do that, Simon.
Yeah, for some reason.
It's the fourth one over from the left, going toward the right corner. It's the last one before you have the little slide button.
Yeah, I'm seeing great on mine. The problem is not because I'm not showing it on you guys.
Try to advance them. I think we can see them. Go ahead.
That didn't work. So you're recording.
I think we can see advance them.
Yeah, I can advance it, but now
Okay.
Is it on yours?
We can see them. We just not seeing the full screen, but that's fine.
Anyway, as Dr. Lawson noted, I'm a board certified psychiatrist, clinical professor at George Washington right now, emeritus of Texas, also emeritus from Howard. There we go. And just to close that, I actually will be discussing some of the Robin clinical trial study. Will not be discussing the Tourette study. Just wanted to note, and first of all, as you folks can probably see, I am a male. I was trying to find a female colleague, so to give me some credibility in what I have to say. So I welcome as much participation from women in the audience in terms of any comments that I made. Epidemiology: 1 out of every 8 women develop depression at some point in life, twice as likely as men to struggle with depression. This is actually a controversial point because what we find in the Western world that women are more likely to develop depression. When we look at some other countries, especially those, interestingly, that have low rates of substance abuse and alcohol use, there doesn't seem to be much difference in terms of sexual differences in terms of rates of depression. But the gender difference doesn't exist in most countries. It can occur at any age, most commonly around 25 to 44. What is depression? The formal definition focuses on the mood, a depressed mood, or some people's irritability, anhedonia, lack of feeling, change. I want to emphasize this change, not necessarily loss or gain, but change in weight or appetite. Change in sleep, not necessarily can't sleep or sleeping too much, but a change in sleep. Change in movement, activity, or retardation. Fatigue, a loss of energy, feelings of worthlessness or guilt, found mostly in the Western world. Diminished ability to think or concentrate. And the most important one, doesn't appear all the time, but something we should always put on the back burner, thoughts of death or suicide. And there's some differences in male and female depression. Again, I'm not saying they're biological, and there's cultural factors that are involved, but we do find that, at least in the U.S., there are some gender differences in terms of certain kinds of symptoms. Women are more likely to have what's commonly called atypical depression, and that says something about a gender bias as well, and that is much more likely to sleep in more rather than sleeping less, eating less, losing weight. Whereas, and also we find women, especially those with seasonal depression, have a carbohydrate craving and gaining weight. Feelings of guilt, more common in women, and women may also have depression earlier in life, and it's much more likely to be associated with stress, and they're more likely to have seasonal depression. Women are more likely to have suicide feelings, more likely to attempt suicide, but men are much more likely to complete suicide. Women are more likely to have anxiety disorders, especially panic and phobic symptoms, and eating disorders, and much less likely to abuse alcohol and other drugs. In women, what we find is that trauma is a lot more common, from physical, sexual abuse, elderly abuse, neglect, and, interestingly enough, often more likely not to be believed. And what we find is a lot more post-traumatic stress disorder. We did a survey, Howard University Primary Care Clinic, and found that over half of the patients, many of them were female, had either post-traumatic stress disorder or major depression, but only 17% were referred for mental health treatment or actually treated, probably because these symptoms were not recognized by the clinicians. What we also find is that during the premenstrual period, in addition to the usual feelings of bloating, many women experience irritability, fatigue, and hyper-emotional reactivity. Again, interestingly enough, it seems to be much more common in women in the Western world. For many women, it's mild, but for some, they are very severe, and we now have a psychiatric disorder called premenstrual dysphoric disorder. Now, what's very common are the postpartum mood disorders, baby blues, postpartum depression, and postpartum psychosis. Baby blues, extremely common. It's extremely common and often either disregarded or because the expectation is that women are supposed to be happy during pregnancy. And yet we found that 50 to 80% may have baby blues for 3 to 5 days after delivery, can last to a few days to several weeks. Some of these folks go on to develop severe major depression itself or even bipolar disorder, and the symptoms are tearfulness, mood instability, sleep disturbances, especially difficulty going to sleep, and of course feelings of guilt and inadequacy about whether or not they'll be able to take proper care of the child. Treatment, straightforward, mostly educate women about what it is, rather than to blame women or to disregard it, to validate their experience, rather than to say, oh, all women go through this, or you just over-exaggerate. These are real symptoms for men and women. And then we need to monitor folks for exacerbation of these symptoms. And what we're concerned about is that 8 to 10% that develop postpartum depression, which occurs about 6 weeks postpartum. It can last for months. And actually, if untreated, it can go on for years. Tearfulness, mood changes, difficulty enjoying oneself, sleep difficulty. We'll say a little bit more about this, but some of the folks actually go on to become suicidal or try to kill their babies. And as again, the feelings of guilt and inadequacy. What are some of the risk factors? Biggest one, of course, is pregnancy, but also miscarriage, breastfeeding, previous episodes, depression during pregnancy, history, family history, as well as history, the depression, some sort of mood disorder, and a history of having this before, and a history of infertility, and a lot of women don't have any risk factors. There's also pregnancy during adolescence. In the news in the past, Tom Cruise was hypercritical of Brooke Shields, who had developed postmenstrual depression and tried to discount it. And she made the point of saying that this is a real problem, real concern. Now, what happens if you don't treat it? Why don't you just let it go, which is what was done in the past, or discount it, or tell women, suck it up, take it. Well, if you don't treat it, it will occur again. It can impact the mother-infant attachment. It can increase infant anxiety. And what we're now finding is that the cognitive ability of the infant is impaired, behavioral development is impaired, and delays in development of the child, increased risk of infants themselves developing depression. There's poor self-care, nutrition. Some women actually turn to substance abuse, and the child increased risk of substance abuse. And of course, the medical emergency of infanticide or suicide. So the long-term consequences are shown repeatedly. And it's interesting that we have to continue to show this because people still disregard it, that it's associated with poor parenting, less secure mother-child attachment, seeing mothers just pull the child away from them, or almost neglect the child, more likely to be inconsistent, lax, withdrawn, or overly intrusive, ineffective in parenting and child discipline behavior. And also the child is more likely to develop problems of self-control, difficulties in cognitive functions, difficulty in interacting with others. And we're increasingly recognized in turn that this is associated with one of those kinds of events, early childhood events that leads to adulthood for physical health, as well as childhood for physical health. They're also more likely to have to use acute healthcare services, the children as well as the mother. Also may be more likely to increase overall health utilization. Interestingly enough, increased risk of accidents of all kinds, childhood asthma, abuse, and also adolescent tobacco and substance use when the parent is depressed. Now, obviously, given this, you want to identify this, and the easiest way you would think is to simply ask the mother, are you depressed or not? But what we've repeatedly shown and others have shown is that many folks in our community just don't recognize depression or call it depression. You ask them, are you sad? They'll tell you no. Heck no, I got a good man, I got a good house, got nice looking kids. No, I'm not sad. So we've identified and developed in many primary care clinics, had these screening tests, PHQ-9, the depression inventory, and many OBGYN programs now have the Edinburgh. These are now good screening tests. The problem is that all too often folks will get the results and ignore them and not follow up. Now, how do you treat postpartum depression? Well, part of it is to recognize it for what it is, be able to provide mild to moderate basic psychotherapy, or even have a supportive person with a program while I was in Austin, which essentially had other women with lived experiences to be there with the mother to help support. It also helps to have a supportive partner, but as you can probably guess, single parent mothers are especially at risk. There's also, is it severe enough that you want to consider pharmacotherapy? So you got to weigh the risk versus the benefits. And there are some folks who are using short-term sleep deprivation because sleep deprivation can have an antidepressant effect that unfortunately goes away as soon as the person goes to sleep. We also have various kinds of therapies that you really have to have training to do them well: cognitive behavioral therapy, the personal therapy, marital counseling. Yeah, making sure that the partner is on board. And there's good old psychodynamic psychotherapy, which many people know the terminology, but unfortunately didn't learn how to do it. So there are pharmacological interventions that's shown to be evidence-based effective. There's a lot of alternative medicines that are used. I just want to know one, St. John's wort does work for mild depression. SAMe works, but omega-3 fatty acids do not work for depression. They help your heart, they help everything else, but they don't work. Exercise we've shown is great. Problem is getting the mother to want to exercise. What we find is that many of the women are just worn out, and the last thing they want to do is go out and start exercising again. Spirituality is shown to be effective, and it doesn't have to be a specific church, but to have a supportive church that can contribute to resilience. And it's not just show up at the church and say, yeah, I am. Actually become involved in terms of the spiritual activities. In severe emergencies, ECT has been shown to be effective. So what about the mother, the baby, and everything? ECT is probably one of the most safest interventions that we have, but it does have physical effects. It does have maintenance difficulties, and it is, but if a mother who is infanticide or suicidal, it's one of the most effective treatments. Light therapy does work. Problem is just getting folks to get the light box and shine it, or getting his insurance they'll pay for it. Melatonin also is helpful for folks who have a little sleep problem. Then, if all of these don't work, or you find that you really need to get the depression resolved, we have antidepressants, and they do work. The problem is a lot of providers are uncomfortable because of the risk, not only potentially to the mother, but to the child, especially in terms of breast milk. What the evidence is now showing is that many of these drugs are safe during and after pregnancy, and really don't go across the placenta barrier that much, so that they're relatively safe during pregnancy. There is some risk, but it's small, and the majority of women is very, very low risk. The tricyclics can cause limb deformities, but folks are not using those now. the big uses in terms of the so-called SSRIs and the atypical SSRIs. Just note the risk. You can go online quickly to find out whether or not the drug is at risk. And of course, the FDA gives a no risk, no evidence of risk in humans, but there may be in animals. C, risk cannot be ruled out, which is unfortunately many of the agents, we just don't have the data. We now have a lot of experience with many of the older medications, that fluoxetine and so forth. We find that the risk is very, 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 very low. There's some like paroxetine that there is some evidence of risk, but again, it's very low. Or X counterindicated in pregnancy, and none of the approved on cases are at that situation. We now have transmagnetic stimulation, which can in many places be used to replace ECT, in which a person sits in a chair like a dentist chair and get and you can in many moderate cases of depression get as good outcome as you can with ECT. Now, one problem is that we don't have more evidence in terms of postpartum depression, is that women have not been included in clinical trials. I was always amazed when I looked at the data, looked at the literature, and said, okay, let's see how many female subjects are involved. And there aren't any. Part of it has to do with historical factors. And in fact, in 1977, the FDA recommended excluding women from phase 1 and phase 2 trials. So we didn't have data. 1989, 1993, there was policy. Then in 93, they finally allowed women to be participating in clinical research. And what about Black folks? Well, women were included, but what we found is that many subjects did not include African Americans, because the idea was that we didn't have to show that, because there was not ethnic differences, and now we know they are. But the other was that a lot of folks, partially because of the Tuskegee effort, just don't want to participate. And there are too many, as we've discussed before, too many investigators who simply do not want to make the effort to reach out to the African American community. And we also have a whole history of negative experiences. And I just want to focus on slavery, where women were used as subjects without anesthesia in some trials to use surgical techniques. And since they were slaves, they couldn't refuse. So we had that negative history that impaired getting people in trials and testing new drugs. Recently, there have been some new treatments. Sage found got a drug out that I and Dr. Faggett, I don't know if he's going to join us, participate in a drug called brexanolone, which was shown to be effective. Not only was it effective, but usually it takes about a week to 2 weeks for antidepressants to work. In this agent, we're able to get effective results in days. However, there were two factors that limited its use in the African American community or in many of our clinics. One is that the drug had to be injected, and frankly, many mental health clinics just aren't allowed prepared to do that. And the other one, of course, is cost. Again, because it's a new agent, it's not going to be easily gotten, and also because of the requirement to have it provided by injection, you had to have somebody who was comfortable giving injections in the center. Nevertheless, it was very effective, worked very quickly, and from our experience, it had very good results. So it's an interesting one. it's not work through the dopamine, norepinephrine, serotonin system, but through the GABA receptor, which says that this may be a drug used for other kinds of depression as well, and not have the kind of side effects associated with these. Now, let me just mention, let me just move ahead a little bit. Okay. Let me just mention one thing that has happened, and you probably saw it today, is that Sage has developed a new variation of this agent that is oral, that is now approved. I see it in newspapers today, and so this should be an agent that will be available for many of our clinics and in the community. And of course, there's no dimension of what the cost will be, and as you know, with the new Alzheimer's drugs, with some of the diabetes drugs, the costs can be substantial if we don't take action to make sure they're already available. Now, some women, a small percentage, but it's 1 or 2 in 1,000 deliveries, and what often puts this in the newspapers is postpartum psychosis. Here's in the first week of delivery. We think it's probably a subgroup of bipolar disorder, and characterized by delusions. Baby, and I'm sure many of you have seen multiple movies, Exorcist and others. The infant is possessed, the mother believes the infant is possessed by the devil, or the infant's got special powers. She can feel the infant controlling her mind. She's convinced that if she lets that infant live, a terrible things happen. Either the world's going to end or the infant's going to die horribly. And have ongoing thoughts of wanting to harm the baby. So this is a medical emergency. Unfortunately, all too often folks discount it when they see it because it's a person who's normally fine, nothing, no symptoms usually until pregnancy. Risk factors: previous history, first child, unmarried, cesarean, having a female child for some reason, personal history of mental illness, fetal distress, or abnormalities in the offspring, cyanosis, and so on. Most commonly associated with the diagnosis of bipolar disorder may need to separate the child from the mother. And even though you think that you want to make sure that the child gets support, there's a real risk that harm can come to the child. With early diagnosis, early detection, aggressive treatment can have a very positive outcome. Pharmacotherapy for at least 6 weeks is usually recommended and may need to be treating a person with antipsychotics. Just wanted to note, we mentioned that it's linked to what looks like bipolar disorder, the symptoms of bipolar disorder, which are often missed in African Americans, include super experiences of self-esteem, racing thoughts, decreased need for sleep, excessive talking, participating in activities like running around, buying sprees, multiple sex partners, frequent altercations. We had a very unfortunate experience in which a young lady, right after delivering the baby, ran out into the street, got picked up by a stranger, took out, and they had the sexual liaison, got on drugs, and then he fortunately came back and dumped her from the emergency room. But and again, this person was normally an excellent mother and was actually married to a resident who was very understanding. And what we also find is that many of these women end up in jail. And as we know, the African Americans are more likely to be incarcerated than other groups. And these women, sometimes when they try to harm the baby, is used as a defense that is ignored. So there's a real problem with trying to educate the criminal justice system that this can be a mental disorder that can be harmful to the child, and incarcerating women is not the way to address this problem. We now have various kinds of psychotherapy for bipolar depression, and these lead to very good outcomes, and they have as good a result sometimes as pharmacotherapy alone. The usual challenge here with folks with mood disorders is that many of our agents, such as lithium and valproic acid, associated with problems during pregnancy. In fact, most of them we have to be very careful. The good news is that the atypical antipsychotics are not associated with many bad outcomes. So we do have a fallback, although they don't often are not as effective in terms of dealing with some of the depressive signs of mood disorders. Then there's the perimenopausal and menopause itself. Women are at increased risk during perimenopause and the early time leading to menopause, as the reproductive hormones happen to fluctuate. A lot of cultural effects, heavily in the Western world, and in third world countries, either it's not reported or they just don't see it. And women who have the history of depression are bipolar or increased risk. How does depression affect older women? Evidence suggests that it is generally occurred with prior histories of depression, but is not, and I repeat, is not a normal part of aging to suddenly become depressed. Loss of a spouse, moving to work and retirement, dealing with chronic illness, all can lead to depression. But because many women are self-sacrificing, want to be supportive, nurturing, just don't talk about the depression, or they may be oblivious to those signs. So the provider may not spot it. Also, there's changes in the body going on, restricted blood flow in the brain, as well as having old adults with no family or personal history of depression may develop what folks call vascular depression, and they may have a risk for a coexisting cardiovascular illness such as heart disease or stroke, which is yet another factor for depression. And also, many of these folks can respond to psychotherapy, but the problem we have is that, especially if they have bipolar depression, they may get misdiagnosed, put on antipsychotics or benzodiazepines when they don't need to be, or think they're not relevant to treatment for elderly African American. Was very relevant because we don't want folks to be on multiple medications where it's not needed. We don't need to have high medication doses. We need to have them more likely to take the medications. You need to have a therapeutic alliance with their physician and improve their investment in care. But what we find is all of these factors are problems in terms of providing care for African American women. So the bottom line is treatment. We got to look at the multiple needs of the individual, including remaining in a therapeutic environment. Treatment should be available no matter what. Should be based on the latest findings in neurosciences. Treat the comorbidities. Post just did a very nice article about these kinds of multiple issues. Just want to, for more readings, Donna Norris and Nell Prim, who's local. Came out with a book on mental health, racism, and contemporary challenges. It's available on Amazon as well as the American Psychiatric Association. And then I've pulled together my lectures that I did, my editorials that I did for the Journal of the National Medical Association. So I encourage you to look at my editorials, and they are listed in the available on Amazon as an ebook or paperback if you wish. And I will now end here and open for questions and comments.
Thank you so much, Dr. Lawson, for this wonderful talk. Dr. Walks, would you care to lead the discussion off?
I would, Dr. Maxey. Thank you very much. Dr. Lawson, thank you once again. Excellent presentation, very informative and also thought-provoking. You mentioned some of the social determinants that impact folks in your discussion, and it seems like these things build one on the other. So there may be a lack of access to the diagnoses that you talked about, and then a lack of access to resources. Can you talk about how those kind of make this a bigger problem? Because not only are folks not being diagnosed, but then don't have access to the treatment even when they are diagnosed.
So there's two sides. So one of them is folks either don't want to or refuse to recognize these as problems, either from family members, from the community, or just the whole idea that we have strong, resilient people, so forth and so on. There's one first story, this whole depression stuff is just a piece of crap. Don't apply to Black women. We too tough for that. And then on top of that, is again, the Post article talked about how many of our community, half of people had access to services. I wouldn't refer to that. When you look at mental health services, you look at Ward 7, Ward 8 versus some of the others, you don't have as many mental health clinics. Many of the clinics don't have physicians or clinical psychologists or extensively trained nurse specialists. We have lived experienced people, but they really need the support and need to have the support for the mental health professionals. And then in our OBGYN clinics, again, some of the folks there, they have the instruments, the tools, they're giving them, but that don't know how to refer folks out so they can get the service that they need. Them don't know how in the world do you get somebody in a mental health clinic? How in the world do you find a psychiatrist? How in the world do you find a clinical psychologist? There's a shortage of these folks in our community. And there's also the huge stigma. There's still a lot of people who think, I'm a supporter of going out and get some spiritual support, but a lot of folks who think when you got something like this, you pray enough, it's going to go away. And you don't, and you're not praying because you're really not believing hard enough. So those kinds of things get in the way of seeking treatment that's necessary and essential. I think I saw someone send up a note about diet. Yeah, it's two-edged sword. First of all, what the evidence shows very strongly is that having a appropriate diet, well-nourished, all your essential elements and so forth, not on some fad diet where you eat chickens on Tuesday and nothing else the rest of the week and so forth, it can have a very positive point about mental illness. But what we found is that some of these just don't help at all. So CBD oil, I mean, it's nice and may help people relax, but there's no good evidence that it works all that well long term. Marijuana, they make you a little bit, but there's emerging evidence that it can have impact on the developing child. So again, having a nourishment, having a good balanced diet, exercise works wonders. But the problem we find is that many of the folks, especially those who are really down in the dumps, don't do that. Lower I just saw a case of a lady who had a program which is teaching single parent mothers how to cook. They know how to cook. And so their idea of a meal was give the child a Big Mac every day. And that was the only thing that the child did. So the child and the mother malnourished. And so again, and the whole issue about access to fruits, vegetables, and supermarkets versus going to 7-Eleven, I think has been discussed on the show already.
Could you speak just a moment on delusion?
Yeah, delusions, surprisingly, I find some folks don't recognize delusions when they hit them in the face. I think everybody's seen Exorcist. Just watched a show last night about In fact, there were about 5 shows on Netflix about the baby having powers to influence the mother. Or if you don't kill the baby, everybody on earth will die, and so forth. I don't think that's convincing people that's the case. But what we do find is that some women doing right after delivery start believing that the baby has some special powers. And by delusion, I mean we call fixed false beliefs, beliefs that are persistent, will not respond to reason, and no evidence for it. It comes out of the blue. And that we have a hard time sometimes to separate cultural beliefs. There are some folks who, there are some cultures who come out and say that if the baby is born a certain way, he must be improved by the devil. Not most cultures in the U.S., thankfully, but they do exist. But they do. But when we find there's a phenomenon Dr. wasn't sure is familiar with, Vallejo do, in which a family member may have something like schizophrenia or other disorder, and a person may not have that disorder, but then begin to believe that it becomes part of the person's family culture to have these beliefs. Second son, if you have a baby on after an eclipse on second Tuesday, he's going to destroy the world or something like that. There are a lot of these beliefs that do float around our communities because we have a multicultural community. And rather than getting second opinions, third opinions, folks sort of keep themselves to themselves. They don't want the family to be looked upon with distress. They don't, and they also think that you, the provider, everyone else, may be in collusion to try to protect the child who's the son of the devil and so forth.
So Dr. Lawson, you mentioned that one of the resources available to treat some of these challenges are medications, and at the same time we advocate for folks to breastfeed, to nurse their babies. Can you speak a little bit about some of the misconceptions and then also the safety with many of the mental health medications that may be prescribed if someone has either significant postpartum depression or they have some sort of a psychotic component to that?
I think the good news is that we now have a lot of resources, so you can quickly find out if the medication is associated with any kind of risk for breastfeeding. I mean, you can go out very quickly and get some very, very reasonable data. I was frankly impressed at how much some of the stuff on Google is keeping up with the latest literature. And you can also, and you really want to go deep into it, you can look on Google Scholar as well as some of the other sites to get the latest of the latest. But still, a lot of people don't do that sort of thing. They just work on the idea that my mama and my grandmama told me that if you took marijuana when you were a little girl, your baby's going to be deformed and all kinds of stuff. So we find in our community, and Howard has a very active program to improve breastfeeding. Our community, all too often, folks have these misconceptions about breastfeeding and won't do it. It's a double-edged sword because breastfeeding is one way to early life to get a good, healthy baby, as well as the effect it has in terms of bonding. But if you don't breastfeed, you better have a good, adequate support system, and in order to get proper milk. And in some cases, unfortunately, folks substitute other things that may not be as healthy for breast milk. So it's and then there's this that don't get into the issue of the social stigma about is appropriate to breastfeed in public? Will people see you? And so forth and so on. So good news is that a lot of folks are now recognizing the usefulness of breastfeeding, recognize we have some alternatives. The bad news is that many folks live in, I won't say impoverished communities in terms of wealth, but impoverished community in terms of health literacy and health resources that can often be gotten, but folks just don't know how to get the information or are not associated in a kind of supportive environment that tell them how to get the information. Again, some of it, again, I mentioned Howard University, George Washington University, the programs reaching out to the community. But a lot of folks in the community are not interested in programs. They want to stay in their own spot, not talk to professionals unless it's a crisis or an emergency, and try to find their own way when they're trying to raise a child early in life.
So Dr. Maxey, I wonder if we can prevail upon Dr. Lawson to use his professor skills for a moment. We had a comment in the chat and a question from Jamar Nash, and I know you can see that, Dr. Lawson. I wondered if we could unmute Jamar Nash and be a little interactive and have him prevail upon you, Dr. Lawson, to respond to to have him ask his question and have you respond to his question.
And I'm in full disclosure, Mr. Nash is working with me in a research project right now, so we've had some dealings with each other before.
Well, there you go. Real time. He decided not to ask you tomorrow, but to put the question out today. So, Simon, is it possible for us? Oh, there we go. You're unmuted, sir.
Sure. Yeah, I just was asking the question because I was not able to see the entire presentation, and there could have been something that I might have missed, but I did catch one that there are similar outcomes sometimes with the addition of a clinical psychologist on somebody's care plan without the use of medication. And of course, I know there are a lot of things I could learn about just takeaways as a young psychologist that I could share with other people at Howard. I go to Howard now, and then also because I saw the mention of barriers to care, and I think that that's always something that I'm very interested in. And I was hoping to hear if there were any takeaways or solutions that you have been able to uncover in terms of working to eliminate some of those barriers to care, or at least make the access to having a psychologist or psychiatrist in the community and finding that to be something that could be helpful for someone's treatment plan.
That's actually an excellent question, and something that it's interesting. This issue keeps coming up, and with a number of places have developed solutions. The real issue is, why aren't these solutions implemented and included into the mental health system and to the education? Because Dr. Campbell has been very aggressive, working with the community in terms of having programs which we're reaching out to community organizations to screen and assess the extent of mental disorders or stress. Dr. Aline and Howard in the mental health clinic has worked with the psychologists there, and we worked with the primary care clinics to develop programs to help recognize mental problems and to screen for them. Surprisingly, though, even though we've done work for showing why that's important, folks at Emory and at Morehouse have done work. Drew Medical School actually have psychologists based in their primary care clinics, which is shown to be very effective in terms of referring folks for treatment. And I've always been an advocate of making sure that we have psychologists or mental health providers involved in our forensic and our police services. It is still more of the exception rather than the rule. So I think the very first thing is to recognize that we have tremendous resources around us that can address these problems. We just have to remove some of the financial barriers that keep clinics and other institutions from generating enough revenue so they can hire folks, as well as the administrative barriers that continue to exist. That we need to have, we need to put these artificial barriers that this is where the psychologist is, this is where the psychiatrist is, this is where the social worker is, this is where the nurse is. We need to be able to have these professions work collaboratively with law enforcement, with primary care clinics, with OBGYN programs, and put it at the top of their list services that they must screen and recognize mental health disorders. And I'm sure, as you well recognize, our effort to reach out to the churches has been very important because in the African American community, the church is a very important institution to recognize not only for the spiritual needs, but historically to keep the community aware of what's happening in terms of resources. So it's important to look out to the churches, the barbershop, great place, and there's some barbershop programs, still the exception, but they are very effective when they occur at a beauty parlor, where folks will come there, shoot the bull, discuss the state of the universe. And one of the things that we can use those places is places to be able to provide provide supportive services. One part of the cultural thing has been what I call the idea of the ivory tower. Academicians work from a distance, do not want to get their hands dirty working in the community. We need to have more programs designed so that folks can actually get hands-on, not only in terms of an experimental closed setting, but also in terms of where people actually are. We struggle with the NIH in terms of, as I've mentioned, folks didn't want to dirty themselves looking at women or pregnant mothers in terms of studies. We had the heck of a time convincing them to do research in the correctional system, where a lot of folks are. And I think part of it is to have folks being able to develop projects that can go out there. And I think it's a positive way for them as well, because what you find is you want to do a dissertation or a new research project, that's where the action is. You'll find that it's often understood, studied areas that can add to the literature very, very quickly.
So, Dr. Walton, Dr. Lawson, I'm wondering if we could invite our psychiatric colleague, Dr. Michelle Clark, in case she wants to make a comment. Is Dr. Clark available?
If we could unmute Dr. Clark, Simon, and then Dr. Maxey, Dr. Sherrod has her hand up as well.
Okay.
Oh, and while we're waiting for that, Dr. Lawson, there was a request that you put a link for your book into the chat, if you could.
Yeah, well, I think, of course, just go online and go to Amazon and put my name.
Go.
Try to make it as simple as possible. I don't want to get.
Why don't we unmute Dr. Sherrod? Dr. Clark doesn't seem to answer. And we're close to the top of the hour.
Yeah, I just want to commend Dr. Lawson on an outstanding lecture as usual. As I learned this phrase at Harvard, your fund of knowledge is exceptional. And I really like your presentations on this. Thank you so much. My question, I just heard on the news just recently, last week, that the state of Arkansas has passed a bill so that postpartum depression is actually covered. The treatment of it is covered under Medicaid. And I was wondering if you have knowledge of the extent of this activity. Is it covered? And, an ounce of prevention is worth a pound of cure. Is it covered when the mother presents to the doctor pregnant? do they start doing things that will prevent, or are there any preventative measures that can be used to anticipate postpartum depression and start working on it during the perinatal period?
I think that's an outstanding question. I haven't been back to Arkansas in a couple of years now, so I'd have to go and read up on what they're doing lately. But I did have some experience with Texas. Texas has very specific rules about what can be covered. They actually laid out that Medicaid only covers certain diagnoses, and that did not include many mood disorders. So it's only recently that again to change that. And unfortunately, the experience that had in Arkansas, Texas, also occurring in many other states as well. And that is a failure to recognize that you don't have to have schizophrenia to require mental health treatment.
Right.
That people with depression, it pays off to do it. And also, women are not immune to depression, which is a surprising belief that's held by folks in the community in terms of including some women, that depression in pregnancies doesn't make sense. So it's something that they can't comprehend. Or that these women who are going around saying they're threatening to kill the baby, just trying to fool everybody. They really want to get rid of those babies because they don't want to have to work and the effort. So we got to punish them. So I'm glad they're making that step. But what's going to have to happen is going to need some advocacy by local providers to be able to start changing these mindsets and to educate their patients in the community that mental disorders are real, mental disorders can be harmful. It is cost effective to treat mental disorders early. And that not everybody who's saying that they're doing bad things because they have a mental disorder are liars. So I think just those kinds of basic things you can do to educate not only white folks, but our Black folks in the community as well. And also that it can happen to anybody.
Thank you so much, Dr.
Thank
Lawson.
you.
Thank you so much. We're at the top of the hour. Dr. Walks, you have some final words?
Thank you, Dr. Maxey. Again, Dr. Lawson, as Dr. Sherrod said, as usual, a very informative presentation. I think it's consistent with what Dr. Lawson said. We sometimes think about mental health as a little bit unclear, and how do you tell if someone has this or that? And one of the things I liked about Dr. Lawson's presentation is that he did mention some of the screening tools, some of the evaluation tools, the depression inventory. There are ways for us to have a real diagnostic approach to when someone is struggling with some mental health issues. And that allows us to bring as much science to the practice of mental health diagnosis and treatment as other doctors do who take a blood pressure or who take blood work. So I think it's important to know that there are ways for us to quantify the science of diagnosis in mental health. And I think that we need to, again, I don't want to go too long, but I also want to emphasize one of the things that Dr. Lawson talked about, which is the stigma that still is in, particularly in our community and some other communities, about if I do this, I shouldn't have that. It is absolutely reasonable for us to go to church and go see our psychiatrist and go see our psychologist, see our therapist, and do all of those things, because all of them can be beneficial for us as we look at how we navigate our way through the world. So that's what I've got to tell you, Dr. Maxey.
Thank you so much. I'd like to express our appreciation from all the people who heeded our email of last week to donate before the end of the year. I've received a number of checks that will be very helpful as we go forward, and I'd like to show our appreciation for that. Next week's program is going to feature Dr. Charles DeShazer, who is in Chicago, and he is an expert of a different thing that we haven't talked about too much. That's artificial intelligence in medicine. And he is one of the most knowledgeable people in the country on how we use or should use artificial intelligence in medicine. So that should be quite interesting. I hope you'll join us again next week. Thank you very much, Simon Cooper, for helping us with the technique. Very good. And thank you, Dr. Lawson, again for the wonderful presentation. And thank you, Dr. Walks. Have a great Sunday.
Good day, everyone.